What is cancer? Gene mutation. Very good, smart girl. Yes. Anything else? So there is a genetic abnormality. That's right. There is a genetic abnormality. Okay. Tumor. Very good. Yes, tumor. Okay. Tumor. More. Swelling. Okay, very good. More. Yes. Abnormal growth. Very good. Well done, dear students. Yes. More. Lagi. Yes.
Abnormal cell
Invasion. Very good.
abnormal cell division.
Abnormal cell division. Very good. Excellent to all of you. Thanks. Thanks. Yes. To those who are participating. Yes. From there. Anyone. Don't let only the front to participate. Yes. And take the honor. Those who are sitting behind. You should participate also. Anything else? What is cancer? Because as an MBBS student, you will be exposed to this with your relatives, with your family, with your friends. Always you're like, okay, what's tumor? They might ask you this. What is tumor? You are studying medicine. Okay, tell us, what is tumor? Then, if you will tell them, tumor is neoplasia, they will say, okay, what is this? What is neoplasia? You never heard about this word, that's right? Did any one of you heard about neoplasia before they joined MBBS? No, that's right. This is pure pathological medical terminologies. We use it in the medical society. Okay? So neoplasia is a scientific, pathological, medical term. And we are going to discuss it. New means new. Plasia means growth. So it's a new growth. One of you, the smart boys, I believe, he said, new growth. So cancer. Then why we call it cancer? Why we call it cancer? Okay, for cancer, there's a shocking cancer facts and statistics. You know that cancer is one of the leading cause of mortality? Yes. Devastating, really. For the patient, it will affect the patient's psychological status, mental, and immunological status. Even the immunity. Once the patient will hear that he or she, they are suffering from cancer, the immunity will start dropping more and more. The mental status will start really be affected more and more. Because nobody will feel this unless they will go through this. And thanks God, nobody of us, we went through this. That's right? Yes. So, but keep it in your mind. Anyone, any human being in this world is what? Is susceptible. So keep it in your mind. Then, for the statistics, there is a statistical facts, very important. Cancer, the second leading cause of death. Cancer, the second leading, what is the first? Cardiovascular, that's right, cardiovascular. Of course, it depends sometimes. It depends on many factors. As an example, in certain areas in the world, the cancer might be the first leading cause of death. As an example, Japan. Because you know the two gifts that the US gave to Japan? Yeah. So they suffer from the radiation. So the gastric cancers, other cancers was the leading cause of death. Others, like those, I'm not sure whether you heard about the Chernobyl. Yes, also any area that been affected by nuclear or radiation, so the cancer will be the first leading cause of death. Those who are living in a really sedentary lifestyle, very modernized, so the cardiovascular disease will be the first leading cause of death. Okay, then. So this is what I was talking about. Emotional and physical suffering influenced by neoplasia. This is very important part, okay? So, the first thing, how to break news. They will teach you how to break bad news to your patient. To tell the patient that you are having, I'm sorry that you are having malignant cancer. Okay. Later, once you will break the first news, you remember this. Okay, to your patient. So the big question, I've been asked this question a lot because I kept this question in there in my PowerPoint lecture. My families, my relatives, my friends, those who are not in the medical field especially, of course those who are in the medical fields, they won't ask this question, okay? So they tend to ask me about cancer. This is the big question, okay? Patients, public often ask, when will there be a cure for cancer? Always they ask me, okay, now the rockets, everything, very advanced, okay? We have very advanced technologies, right? AI, everything is advanced. Why you in the medical field, you cannot treat patients suffering from cancer? Why? When there will be a cure for cancer? This question I've been asked a lot, many times. And it's not easy sometimes to simplify it to the layman, those who are not in the medical field. So, what do you think? Is it easy?
No.
So this is the answer to the simple question. It's difficult. Why is difficult? Because cancer is not one disease. Many disorders that share a profound growth dysregulation that can lead to unlethal changes to the cell. And this is the problem. Before, when we studied, when they taught us medical pathology, they said that they called the cell mad cell. Means the cell just replicate, mitosis. That's right, uncontrolled mitosis. Nowadays, when I read and I remember what they told us in the lecture, I would say, okay, this was very basic. Now the microenvironment of the tumors playing a huge, really, I mean, and really affecting the regulation of the cancer cells. What else? Not only this, many other factors we have, many other genetic factors, translocation, deletion, gene mutations, many, okay? Then, so it's difficult, that's right? But, you know, human beings, they always like to have a challenge and they will win at the end. So the scientists trying to beat the pathogenesis of cancer and trying to cure 100% cancer through different, either through the what you call chemical, like chemotherapy, through immunotherapy nowadays, targeted therapy, hormonal therapy, and radiotherapy, whichever, they are doing their best. But we'll see who's going to win, cancer or human. So cancer is not one disease. It's not one disease. Because cancers follow the cell of origin. This is very important. You'll go back now to your what? Yes? Yes? Excellent, smart girl. To your histology. Thanks for trying. To your histology. Because now you are going to classify the cancer based on the histological classification. We have blood cancers originating from blood cells, white blood cells. We have gastric cancer, GIT cancer, originated from the epithelial lining, as an example, or glandular. We have lung cancer originated from the lung. We have brain cancer originated from the brain tissue. Can you see? Different types of cancers. Some cancers, until this moment, are unclassified cancers. They don't know what's their origin. So, we have GIT. Then, this is the second leading cause of death in female, in women. Okay? So, breast cancer. And there is a lot of classification. But by the way, when I say cancer, for each organ, there's like 30, 50, 70, 100 classification for each cancer. But I'm not going to go into these details. We won't finish until year 5. So, initial presentation of the breast mass. Sometimes, if the breast mass will be presented like this, fungated mass, this is the worst, because in this case, it means an advanced stage. This is an advanced stage. We don't want a patient to be presented in this stage. We want early diagnosis. So we will have better prognosis. If it's like this, the prognosis will be very poor prognosis. So breast mass, as you can see, fungated. Then I'm going just to mention that there is something called the PET scan. PET scan is one of the imaging modality going to scan the body and going to discover whether there is any metastatic foci, whether there is any metastasis. Means there is any spread to the cancer from the uptake of a specific dyes, okay, in the body, as you can see here. Then, carcinomatosis. What is carcinomatosis? Well, this will happen either by PET scan, the one that I just showed you, radiologist will discover, or the surgeon. Once the surgeon will open the body, open the abdomen as an example, will expose like this, we'll see there's a dissemination of cancer in the whole body. Can the surgeon remove all this cancer? Unlogic. Never. Usually they will close and they will send the patient to either palliative care or at home just to rest. They cannot do anything in this case. Okay? Sometimes the patient might come with such oral cancer. Those are cases that I diagnosed. Real cases, by the way. Okay? So you can imagine when the patient will come with this oral cancer. The patient, by the way, in this case, she lost more than 15 kg because she cannot eat. Can you imagine? And this is the squamous cell carcinoma, also oral ulcer. Then, the word tumor means literally an abnormal swelling, okay? And cancer is word used in the public, has emotive content, and it refers to the malignant neoplasm. You studied something very important in the acute inflammation. You studied the cardinal signs of inflammation, which is 1, swelling, 2, 3, 4. Then they add. Very good, well done. So, swelling, what do you call it? Okay, we have tumor, ruba, cola. You study this or no?
Yes.
Yeah, very good. So there's tumor, that's right?
Yes.
Okay, so there's tumor in acute inflammation and there is tumor in neoplasia. So, why they call it tumor now? Because there is swelling. So, is every swelling a tumor?
No.
But every tumor is neoplasia, that's right?
Yes.
Yeah. So, keep it in your mind. Not every swelling is tumor. Not every swelling is tumor. It could be swelling due to edema. What is this? Swelling. What do you think? Yeah, could be trauma, could be inflammation, could be also tumor. We don't know. So, very good. So, by definition, tumor, neoplasia, is a lesion resulting from an autonomous or relatively autonomous abnormal growth of cell. Then, any nucleated, keep it in your mind, dear students, any nucleated cell in the body may undergo neoplastic transformation to form a tumor neoplasia, a new growth. Any, when we say any, means any nucleated cell in any patient that you're going to see can transform and form neoplasia. And by the way, for your information, maybe this is the first time you will hear this, any tumor in the world, in any human being, is going to start from one single cell. Do you know that?
Yes.
It's a one single cell disease. This single cell, it will start the transformation due to either deletion, mutation, translocation, methylation, whichever, any genetic abnormality, then it will start the abnormal replication, abnormal mitosis. So any cancer in the world, in any human, it will start from?
One cell.
From?
One cell.
Okay, from one cell. Very good. Well done. So neoplastic cells grow to form abnormal swelling or tumor mass, but this is except for blood malignancies, which is, they call it leukemia. Okay? But to be honest with you, leukemia sometimes it will go also for a mass, forming mass also. But this is advanced for your level. But note that the swelling or organ enlargement can also result from inflammation, hypertrophy, as we studied this. You remember left ventricular hypertrophy?
Yes.
Increased size or hyperplasia, increase in number. So it could be either or. But we should exclude then, now, nomenclature. The neoplasia, as we mentioned, is the new growth. And the new growth is called neoplasm. Neoplasm. Neoplasia means a new growth. Then tumor is said to be benign. Benign when it is microscopic and gross characteristics are considered relatively innocent. Then it will remain localized. Then cannot spread to other sites. Then amenable to local surgical removal. It can be surgically removed. It can be surgically removed. Okay. Are you okay? Okay, very good. So, innocent, not spreading, not invading, and surgically removed. So this is the characteristic features of any benign tumor. Because that we call it benign tumor. Because it's not going to invade, it's not going to spread. Very important. This is what differentiates benign tumor from not invading, not spreading, not metastasizing. Means very good. Keep it in your mind. Now, malignant tumor are collectively referred to as cancer. This is in the public. Drift from the Latin word for crab. Do you like crab?
Yes.
Oh, I see. Okay. A lot they like seafood.
Yes.
Very good. Because they adhere, the crab, of course, here, adhere to any part that they seize on in an obstinate manner similar to crab. So, the crab can, I think this is in the cartoon only. Okay? So, can adhere to any part that they are going to catch it. That's right? So, anciently, when they saw that this tumor is very easy to invade, very easy to spread, very easy to catch up with any other tissue. So they call it what? Cancer. So now you should know why they call it cancer. Because it mimics the behavior of Very good. So, cancer derived from the Latin word for? Very good. So you like it. Most of you, very good. So, then this one, this crack actually, it can adhere to any part that they seize on in an obstinate manner similar to the crack. So this cancer, it looks like the behavior of the crack. So because that they call it cancer. Very good. So very important points. All tumors, dear students, all tumors, benign and malignant, have two basic components. Two basic components in any tumor, except leukemias, to be honest. One, the neoplastic cells itself. Any neoplastic cells, from hepatocytes, from gastric, from brain, from spleen, from skin, from any part. The neoplastic cells by itself. Then, what else? It's not only the neoplastic cells. There is a very important environment surrounding the neoplastic cells to provide those neoplastic cells with nutrients, blood supply. And there is a lot of cell signaling going on between the microenvironment and the neoplastic cells. Okay? So there is a microenvironment and there is neoplastic cells. Very important to keep it in your mind. Then, those neoplastic cells are clonal neoplastic cells that constitute the parenchyma and reactive stroma made up of connective tissue. So, the microenvironment, there is connective tissue, fibroblast, blood vessels to support, we call it angiogenesis. Maybe you study angiogenesis in healing, but this is bad angiogenesis, not good angiogenesis. Then, there is a variable numbers of macrophage and lymphocytes. So this is the reactive stroma of the neoplasms. Then, as you can see here, those are the neoplastic cells. Those are the invasive tumor cells. And as you can see in the microenvironment, there is a macrophage, there is a endothelial cells here, macrophage, endothelial cells. So this will represent the microenvironment of the neoplastic cells. Then, benign tumors. In general, benign tumors are designated by attaching the suffix OMA to the cell of origin. OMA, you remember? OMA to the cell of origin means that it is benign or malignant? Benign. Are you sure? Yes. In general, very good. Very good. Very smart. Yes, in general, that's right. Because there's exceptions. We will discuss it later. So OMA with hepatoma, that's right? Benign or malignant? Benign or malignant?
In general.
Benign or malignant? Benign. Benign or malignant? Malignant. Yes, this is the exceptions. Okay, so as an example, melanocyte, that's right? Melanoma, benign or malignant? Benign or malignant? Malignant. This is exception also. Okay, so there is exceptions. Yeah, very good, smart boy, very good, well done. Yes, so now let's focus on the benign first, then we will come to those malignant that with the OMA. Okay, so of course, for the benign, it doesn't matter whether the cell of origin are, because we are going to focus on this. All of you, focus with me. All of you, look at me. Look at me. All of you, don't sleep. Yes? Look at me. Yes, very good. In our classification, whether benign or malignant, we have two things. We have the epithelial origin cells, and we have the mesenchymal, which is connective tissue origin. You understand? Because in our body we have epithelial and mesenchymal. That's right? Very good. So, for the benign, whether it is epithelial or mesenchymal, it doesn't matter. Both with OMA. As an example, any glandular structure. So we call it adenoma. Adenoma. This is epithelial, that's right? You agree?
Yes.
Very good. Now, for any mesenchymal, what we used to call it, as an example, I will give you example, bone. Osteoma. So osteoma is benign. But what type? Is it epithelial or connective tissue? Mesenchymal? Very good. Connective tissue, mesenchymal. Well done. Lipoma. This is for adipose tissue. And this is mesenchymal. Chondroma. Benign. Which is cartilage, which is connective tissue? Mesenchymal. Very good. What else? Fibroma. Very good. Connective tissue? Benign also. So, it doesn't matter whether it's for the benign, it doesn't matter whether it's epithelial or connective tissue, both with OMA. Both with OMA, okay? So, good. Keep it in your mind. Now, malignant tumors. Malignant tumors. For malignant tumors, we have two types. It follows the epithelial and mesenchymal. Very good. It follows the epithelial and there is a difference in the malignant, but in the benign there is no difference. Very good. Keep it in your mind. So for the mesenchymal origin, as an example, osteoid, chondroid, lipo means adipose. Okay. So there's no OMA, no OMA anymore. No OMA now. Now we are going to use for the mesenchymal sarcoma. Sarcoma. Okay? For the, as an example, osteo. Sarcoma. Lipo.
Sarcoma.
Very good. Chondro.
Sarcoma.
Very good. Okay. Okay. Skeletal muscle tumor. Skeletal muscle tumor. Myo. Okay, very good, very good. Yes, well done. Well done, yes. Yes. Anyone can help. Skeletal muscle tumor. Tumor means a malignant in this case. Yes? Rhabdomyosarcoma. Rhabdomyosarcoma. This is for skeletal muscle. Rhabdomyoma means benign. Rhabdomyosarcoma means malignant. Okay, for the smooth muscle cells, benign and malignant. Smooth muscle cells. Yes. Leo. Oh, okay. Who's? Okay, excellent, excellent. Yes. Benign. Excellent. Malignant? Excellent. Well done, smart girl. Very good. Yes, thank you very much. Leiomyoma for the benign. Leiomyosarcoma for the malignant. Very good. So this is for the malignant tumor rising in mesenchymal tissue are usually called sarcoma. And this is from the Greek. Okay? So malignant neoplasm of epithelial cell origin drift from any of the three germ layers are called carcinoma. So you cannot call it leiomyocarcinoma. No, leiomyosarcoma. But for the carcinoma, it means, once I will say carcinoma means the origin is epithelial, or it's epithelial origin. It's not mesenchymal origin. Keep it in your mind. So, because I might play with you during the exam, dear students, keep it in your mind. Like if I will say that adenocarcinoma is a epithelial origin, mesenchymal origin, connective tissue origin, like this, okay? So you should know it's epithelial origin. Or the opposite, like leiomyosarcoma or rhabdomyosarcoma or osteosarcoma or chondrosarcoma, it's an epithelial origin. Right or wrong?
Wrong.
The right?
Mesenchymal.
Very good. So now you can differentiate between the mesenchymal and the epithelial origin. Now, again, nomenclature for the benign tumors. OMA, benign neoplasm, not carcinoma, not sarcoma, not lymphoma, not melanoma. Okay? So mesenchymal tumors, we have the mesoderm, we have the chondroma, cartilaginous tumor. For the fibroma, fibrous tissue. Osteoma for the bone. Epithelial tumor from the ectoendo, we have the adenoma, tumors forming glands. Adeno means glandular, originally from glands. Then papilloma means tumor with finger-like projection. Whenever you hear papilloma means you should think about finger-like projections. Then papillary cyst adenoma, papillary and cystic tumor forming glands. Then the polyps, a tumor that projects above a mucosal surface. It's a protrusion of a mucosal surface from the mucosal surface, okay? So it looks pedunculated. This is the polyps. We have nasal polyps, we have colon polyps, that's right, GIT. So, what is this? Finger-like. So, very good, very good. Okay, papillary adenoma of the colon. Okay, finger-like projection of the tumor. Now, when we call it polyps, can you see here there is a protrusion in the colons from the mucosal surface? So we call this colonic polyp. It's a gross appearance of the colonic polyps, and sometimes called tubular adenoma also, or adenomatous polyp, or villous adenomas. But this is, you can call it polyps, colonic polyps. It's a protrusion from the. Now, for the malignant mesenchymal tumors, the cartilaginous, chondrosarcoma, fibrosarcoma, bone. Very good. So this is, you should keep it in your mind and you should memorize it like you memorize your name. Because if any mistake with this basic information means that you are going to have 0, and I will consider it as a fatal mistake. Okay? Fatal mistake, there is no mercy in fatal mistake. Because those are basic things. Now, carcinoma, epithelial tumors. So we have the glandular forming tumors, adenocarcinoma. When we say adenocarcinoma, means those are glands, epithelial tissue glands. Then squamous cell carcinoma, it is a squamous differentiation, okay, like skin as an example. Undifferentiated carcinoma, and this is the one that I mentioned to you in the beginning, that some tumors we cannot really differentiate from which tissue or region. Is it squamous, glandular? Is it mesenchymal? Is it epithelial? We cannot differentiate sometimes. So you call it non-differentiated or not differentiated. Carcinoma can arise from ectoderm, endoderm, or less likely mesoderm. Now, this is a carcinoma. This is a carcinoma. But this carcinoma is arising from, what do you think? Okay, okay, very good. Thanks for trying. Thanks for trying. Dear students, you must be very good in histology to diagnose tumors. You must be very good in histology to be very good in histopathology. If you are not good in histology, your histopathology will be very poor. Okay? So we have one book for pathologists, histopathologists, we call it Histology for Pathologists. Okay? Yes. The histology, because that you studied histology in your first year. So when you come to us, it will be easier for you to understand what's going on. This is a squamous cell. Yeah, this is a squamous cell. As you can see here, on the top, those are squamous cells. Can you see? With some keratin here on the surface. So squamous differentiation. Then those squamous islands, as you can see, or nests we call it, are not in the right location, places. It's supposed to be here on the top, not invading. So once you start invading, it means that it is abnormal. So this is invasive squamous cell. Carcinoma or sarcoma? Carcinoma because it's epithelial. Very good, very good, very good. Well done. So this squamous cell, carcinoma, is originated from this squamous differentiated tissue. Now maybe with a yellow arrows, as you can see here, this is the hallmark of what? Squamous cell carcinoma. In squamous cell carcinoma, because those squamous cells with keratinocytes, it will produce keratin, that's right? On the surface. It's supposed to be on the surface. But now because those cells are abnormal cells, it's going to produce keratin here. So do we call this keratin pearl? Keratin pearl. Okay? With nest of keratinocytes. Keratin pearl with nest of keratinocytes. And this is the hallmark of squamous cell carcinoma. Then, sometimes, of course, it follows the differentiation, and we're going to discuss now the differentiation. Sometimes the tumor is not what we call it well differentiated. What is the meaning of well differentiated? Well, if I will ask you now, show me your parents' photo, all of you. If I'll ask for your parents' photo, then I will show you your parents' photo and your photo. That's right. Do you see any matching?
Yeah.
Any similarity?
Yeah.
Yes or no?
Yeah.
Definitely yes. That's right.
Yeah.
There is no doubt about it. We will know that. This is your parent. This is your mother. Either you look like your dad, or you look like more. That's right. Or sometimes in between. So it means that you look like your parents. That's right. The differentiation in tumor, when we say well differentiated, it means that those cells, neoplastic cells, still they look like their parent cells. Means that still they look like squamous, still they look like hepato, still they look like adeno, still they look like whatever other cells. Whenever they are going for more aggressive behavior, they will start looking like not their parent cells. So we call it moderately differentiated. If they don't look like their parent cells anymore, we call it undifferentiated. You understand now? Very good. So this is well differentiated because those type of cells are producing the keratin. But in this case, it is not really well differentiated. This is moderately differentiated. Moderately differentiated. So there is an intracellular bridge normally between the squamous cells. There's intercellular bridge. So we are going to look at the intercellular bridge, and we will know that Those are squamous cells. Now, done for the benign, done for the malignant. Done for the benign, whether it is mesenchymal or epithelial. Done for the malignant, whether it is mesenchymal or malignant. Do you think the story ended? No. There's some exceptions. Okay? So, there is something called mixed tumor. Mixed tumor. Okay? So, mixed tumor is, it's either benign or malignant, by the way, but it's connective tissue and mesenchymal and epithelial. So here we have pleomorphic adenoma of salivary gland. There is a salivary gland, there is a glandular structure, but there is also myoepithelium, means mesenchymal. There is a carcinosarcoma. Now started becoming more complicated, that's right? You should focus. When we call it mixed tumor, means in this case we are having two types of cancers at the same time. Cancer from the epithelial and cancer from the mesenchymal. So we call it carcinosarcoma. But it's not that common. It's not that common, but you should know about it. Then, there's something called teratoma. Have you heard about this before? Yes. Very good. Well, teratogenesis, very good, well done. I think in embryology, very good, very good. Tumor comprised of cells from more than one germ layer. So, those are the gonads. Gonads, okay? Arise from the usually the gonads, and it is a benign cystic teratoma of ovary, the most common teratoma. Then misnomers. The misnomers, the smart student, actually he figured it out. Those are the misnomers, means going to mislead you. It is with OMA, but it is not benign. Keep it in your mind because those are the only one mostly in the practice, so you will know. When I will say hepatoma, in this case, benign or malignant? Malignant of what?
Liver.
Malignant of liver tumor. But this is old name, not being used anymore. But some old, what I call senior, maybe physicians, they might use it. So when they will say hepatoma for you, and you are still junior, and you don't know, you go and write it as a benign tumor, then they will scold you. Okay, so just for your information. Melanoma, malignant skin tumor. Nowadays they call it malignant hepatoma, malignant melanoma. By the way, the hepatoma being changed totally to hepatocellular carcinoma. Hepatocellular carcinoma. Now, for the seminoma, unfortunately, it's still seminoma, and it is malignant. And when I will teach you, or maybe any one of our respected pathology team will teach you seminoma and the male reproductive system, you will directly say, oh, this is benign, because OMA. No, this is malignant. Keep it in your mind. This is malignant of the testicular tumor. Then, when I will teach you, usually I will teach you lymphoma and the types of lymphoma. So lymphoma, keep it in your mind, it is malignant. It is not benign tumor. Okay? So it's a malignant tumor of lymphocytes. Now, what is this? Yeah, what is this? Okay, but what is inside the ovary? Cyst. What is inside the cyst? Benign, okay, very good. So benign, okay, I agree. So what is inside? Do you know what is inside?
Is it hair?
Yes? Anyone knows?
Hair.
Hair, that's right.
Teeth.
Teeth, that's right.
Yeah.
Sebaceous.
Yeah.
So anyone will lose their teeth, they can get from the teratoma.
No. Thank you. I pass.
Okay, but do you imagine there is a teeth in the ovary?
Yeah.
Why? Because it is from the gonads. This tumor from the gonads. So you expect any odontogenic teeth. You expect any skin, sebaceous. No, inside yes, because this is a tumor. Okay, because this is a tumor. We're talking about tumor. Then you expect hair and hair follicles, because this is a tumor of the germinative cells of the gonads, undifferentiated. So it can differentiate to any other tissue. So this is teratoma. Keep it in your mind. This is a gross appearance of open cystic teratoma of the ovary, and there is a presence of hair, sebaceous material, tooth, and sometimes you don't need really, but of course for pathology you need, but this is just for fun. You don't need a microscope to say that this is what? Teratoma. It's very clear that it is teratoma. So with that, I will give you 5 minutes break and come back, please, students. Thank you.
Teratoma.
This is a tooth inside, and there is hair follicles with sebaceous material. This is a mature teratoma. It's benign. Very good. Now, the natural history of malignant tumors. For the malignant changes in the target cells, referred to as transformation. Transformation. Any malignant transformation, any transformation from normal to abnormal, we call it transformers. Oh, sorry, we call it transformation. We call it transformation, okay? We call it transformation. Transformation from the normal to abnormal. From the normal non-neoplastic to the abnormal neoplastic cell. Then growth of the transformed cell. The cell, once it will transform, it will start having what? There will be a lot of growth factors there to give this cell a very good initiation and promotion to what? To proliferate, to grow. So from one single cell, it will become a mass. This is one single cell, it becomes mass. Then, what else? Not only this, because it's malignant, it's not going to be localized. So it's going to, very good, well done, thank you very much. Before metastasizing, it's going to invade. It needs to invade, then it will metastasize. Very good. So it will, what is the hallmark of malignant tumors? Local invasion or invasion and metastasis. Those two are extremely important to differentiate between benign and malignant. Then after local invasion, what next? Distant metastasis means spreading. Because that they call it malignant. Because of the local invasion and the metastasis, they call it malignant. Then, differentiation and anaplasia. I already mentioned this to you, dear students. Differentiation, it refers to the extent to which neoplastic parenchymal cells, resemble the corresponding normal parenchymal cells, both morphologically and functionally. And this is what I mentioned to you when I will show you your photo and your parents' photo. You look like your parents, and sometimes you behave like your mom and your dad. And sometimes when you are young, you're going to sometimes argue with your mom and dad about some behaviors. Once you will be like them at the same age, you will behave like them. Believe me.
Yes.
Okay? Sometimes you criticize them. Sometimes, if not really so, you are not in so good relation, and we don't hope that. Okay? You start criticizing them. You are doing this. You are doing this. Once you will be at the same age, you'll do worse than.
Damn.
Because your genetics are same. And some behaviors are genetics.
Oh my god.
Yes. So be nice, be kind with your parents. Yes. Lack of differentiation is called anaplasia. Lack of differentiation is called anaplasia. Then I can give an example about this without any criticism, okay? But let's say some parents, they don't used to have kids, so they will go to the they will go to and adopt. If we don't want to make it like this, we will go for animals. That's right, like cat adoption, dog adoption, like this. If you don't want to make it human, okay? Yeah. So for adoption, let's say for adoption, they will adopt boy or girl, and they don't used to have really biological siblings or boy or girls. So what they are going to say, they are going, sometimes some parents, they are not going to tell the truth. They are going to tell that you are our boy, you are our girl, okay? Without telling them the truth. So once this poor boy or girl, they will become mature, and they will look at their parents' photo and his or her photo, they will realize that there is something wrong. You understand? There is no resemblance. Lack of differentiation. There is an anaplasia. They don't look like their parents. Even sometimes the behavior is not, because there's no genetics between them. Understand now? What is lack of differentiation? Anaplasia. Those cells, they don't behave like the original parent cells. Like, as an example, hepatocytes, it's malignant. It doesn't behave like the original hepatocytes, which is very beautiful cell, doing a lot of functions, good functions. Now this cell is not doing anything. It's doing bad functions. I'm talking about the cells, by the way, now. Okay, very good. So, you understand differentiation? So, whenever the cells look like their parents, behave like their parents, work and function like their parent cells, they are good. That's right? Well differentiated. Very good. They are moderately looking like their parents, moderately behaving like their parents, moderately differentiated. So, they are not looking like their parents, not behaving, not functioning. So, they are poorly differentiated or undifferentiated. You understand the differentiation now?
Yes.
Very good. So, Faham? Faham, very good. Yes. Sorry, this is in Bahasa. So, well-differentiated neoplasm resembles mature cells of tissue of origin, like their parents. Function and morphology. Poorly differentiated neoplasm composed of primitive cells with little differentiation. Then, undifferentiated or anaplastic cell, anaplasia, means tumor will never look like their parent cells. They are not looking like their parents. Of course, in this case, it's not adopted, but they don't behave, they don't look. Because they are going back to the primitive. Remember, why? You didn't ask me why. You're supposed to ask me. Okay, when I ask you, you should ask me. Okay, I'm not going to tell you. So you should ask me why.
Why?
Because lack of differentiation means going back to the primitive, to the embryonic primitive. Okay, not mature. Not mature. Okay, lacking of differentiation, lacking of maturity. Going back to the primitive, okay, like embryonic looks like embryonic. So, we need to correlate with biological behavior. The tumor usually have a good and bad behavior, like human beings. Always we have good and bad behavior. That's right? You agree about that?
Yeah.
Very good. So, benign tumors are well differentiated. They look like their parent cells. They grow slowly. They behave really innocent. Good. Poorly differentiated malignant tumors usually have worse prognosis than well differentiated malignant tumors. Okay? So whenever the tumor, if it's both are malignant, but one is poorly differentiated, one is well differentiated. The well differentiated have a better prognosis than the poor differentiated. You understand now? Very good. So,
Yeah.
looks good or bad?
Bad.
Okay, of course, some of you will say, okay, you cannot judge. But let's say if you are walking around at night and some of those will appear to you. What do you think?
bad.
Are you going to think in a good way? No. Okay, this is up to you. You said no. I didn't say anything. So because I've been criticized, minimal, okay, criticism, that you cannot judge. But this is just to make it clear for you, okay, for the cells. We are talking about the cells, okay? So, when the cells looks really bad, they behave bad. Not well differentiated, undifferentiated, anaplastic, whenever going for immature, embryonic, they look bad, they behave bad. Very good. So, it looks bad, they are probably going to behave bad. So looking bad in this, not looking like their parent cells, okay? Now, looking, we don't know. For human beings, it's not like always those who were wearing tie and nice suit. We don't know. Not always they are behaving good. But in general, let's say, in general. That's right? In general? Yes. Okay. Because those who wearing suits, they look very smart, okay? Very handsome. But sometimes their behavior, we don't know. Yeah. I think you know what I'm meaning. Okay, very good. Not in Malaysia, outside. So, if cells look good, they are probably going to behave good. Then, looking good means looking like the cells they supposedly arose from, the parent cells. Okay? So those cells, if they look like their parent cells, most probably they are going to behave good. So what is this? This is, yes, smart girl. Yes. What is this? Yes. What is this? It's benign. Okay. You mentioned two. One benign, one malignant. So, what is this?
Oh, yes. Benign.
Skeleton.
Yes?
Skeleton.
Yang
Leo?
Leo.
Leiomyoma. Very good. Well done. This is leiomyoma. Yes, this is leiomyoma. This is the smooth muscle uterine benign tumor. Now, let's look at it. Here, as you can see, this is the leiomyoma. It's a well circumscribed, we call it. Well circumscribed. No invasion. No invasion. Well circumscribed, no invasion. Now, here, what do you see? What do you see in front of you? Smooth muscles, that's right. It's a benign smooth muscle tumor. But in this photo, there is two photos. Maybe you didn't realize. This is one, and this is two. Why I embedded this? Because this is the normal. This is the normal histology of smooth muscles. Then, it looks like
Abnormal.
Yeah, this is abnormal, but still it looks like their parent cells. Still resembling. Still there is a resembleness. So when there is a resembleness means well, poor, un. Well differentiated. Well, poor, un means well differentiated, poorly differentiated, undifferentiated. So what do you think?
Well.
So looking good,
Looking good.
behaving good. There is no. Very good. This is benign tumor. So benign versus malignant tumor. We have features, rate of growth, differentiation, local invasion, and metastasis. For benign tumor, usually progressive but slow, mitosis is few and normal. This is for rate of growth for the benign. For the malignant, there will be a variable mitosis more frequent and may be abnormal. This is for the malignant. Differentiation, the benign, well differentiated. For the malignant, some degree of anaplasia means that they don't look like
The
the parent cells. So they look bad, they behave
bad.
behaving bad, going for local invasion. That's right. So local invasion, yes in malignant, no in
Don't
benign.
invite you.
Cohesive growth, capsules and basement membrane not breached. There is no breaching of the basement membrane. There is no breaching of the capsule in benign tumor. And this is our function as a pathologist. Our job is to say that there is no invasion, no invasiveness. Then poorly cohesive and infiltrative. Where? In malignant tumor. Okay? Metastasis definitely absent or present in benign. Absent. You will be asked about this in the exam, by the way. This is very important slide. Well, metastatic in malignant may occur. Not all malignant can be metastasized, but most probably it can metastasize for the malignant. But for benign, there is no metastasis. If there is metastasis for benign, means it's going to transform to malignant. Very good. So, anaplasia. How do you know that this cell under light microscope it's a malignant or neoplastic cell? There is cytological features of malignancy. Cytological features of malignancy. By those features, you will know that this is malignant cell. So, anaplasia again means cancer. Going back to the undifferentiated. Now, there is something called pleomorphism. Pleomorphism, what does it mean? Means the cell size and shape will be variable. That's right. There is a differences in the cell and shape and size. There's some small cells, other large cells, other medium, other micro, other macro. This is for the cell size. Then the shape, it's totally different. Not uniform. You remember when they look good? Uniform, that's right? Yeah, so the cells are uniform. On the basement membrane, settle on the basement membrane, standing on the basement membrane, and uniform. This is the normal. When they are not going to be uniform, so they will call it pleomorphic. Different shape, different size. Abnormal nuclear morphology. What is the abnormal nuclear morphology? We call it hyperchromasia. Increase in the staining of chromatin. Basophilic staining will take more stain because it's active chromatin. It's ready for continuous replication, mitosis. High nuclear cytoplasmic ratio. Usually the nucleus is larger than the cytoplasm, or the cytoplasm is larger than nucleus. It's larger than nucleus. This is in normal, that's right? Yes. But here will be the opposite. Increase in nuclear cytoplasmic ratio. because the nucleus is very active and ready to divide. Chromatin clumping and the prominent nucleoli. Usually the nucleoli is not really prominent under light microscope, but when it's neoplastic cells, we are going to look at it, then we'll see a prominent nucleoli. This slide, you should memorize it like you memorize your name. Okay? Mitosis. Mitotic rate will be high in malignant. Location of mitosis and loss of polarity. So, pleomorphism refers to the variation in cell size and shape. Thus, cells within the same tumor are not uniform, but range from small cell with an undifferentiated appearance to tumor giant cell. Abnormal nuclear morphology means increased nuclear cytoplasmic ratio and hyperchromasia. So, those are the different types of tumor giant cell. But here, I'm showing you the non-tumorous giant cell. You remember the Langhans in TB? Foreign body giant cell? Those are non-malignant, but those are malignant. We have the anaplastic cancer giant cell, the rhizomyx cell in Hodgkin lymphoma, and the osteoclastic tumor giant cell. Those are tumor giant cell. Now, have you seen such a bizarre shape? There is no such thing. You never saw this before in histology. That's right? Yes. Because in histology, always the cells are behaving normal. Good. Because they look good. Those cells, they look good? No, they look
bad.
Okay, you are saying, not me. Behaving?
Bad.
How? By continuous
Replication.
mitosis. And you can see the nuclear cytoplasmic ratio. At first, pleomorphism. You can see very small cell, very large cell. The shape also different. So shape and size different. Variable, that's right? Variation. Then, what about the nucleus? Increase in nuclear cytoplasmic ratio. Hyperchromasia. Hyperchromasia. And definitely there is mitosis. Mitosis. Okay? Mitosis, mitotic figure. Then more, worse. Yes. As a pathologist, histopathologist, once we will observe, we will see such things. Under light microscope, we will realize that there is something going on. There is bad behavior. Because they look bad. Bizarre shape, we call it. Pleomorphism, nuclear and cellular pleomorphism. Variation in the cell, nucleus shape and size. What else? Hyperchromasia. Increase in nuclear cytoplasmic ratio. Mitotic figure here. Mitosis. Mitosis. So, the cells look, behave.
Bad.
How? By invasion and metastasis. Very good. Well done. So mitosis. In benign tumors, usually the mitosis will be low or absent. But in malignant, there is mitosis. And our job as a histopathologist under light microscope is to count the mitosis in the high power field. We should count it because we know that the percentage of mitosis, if it's more than this, it means it's a very aggressive tumor. So counting the mitosis is our job as a histopathologist. Then, presence of mitosis or mitotic figure also, very important. And the mitosis sometimes will be very bizarre shape, very abnormal, like this. Like this. Can you see? Do you know the normal mitosis? Bipolar, that's right? Yes. Beautiful, that you have studied in maybe year one, maybe in school. Yes. But have you seen such thing before? Honestly speaking. No, this is a nuclear abnormality, mitosis abnormality. Okay? You can see different types of abnormal mitosis, and this is not really a normal mitosis. Whenever it's going for more bizarre shape means the behavior is more and more.
Abnormal.
More and more?
Abnormal.
Okay, you are saying. So differentiation and anaplasia, loss of polarity, in addition to cytological abnormality, the orientation of anaplastic cells with respect to each other's or to support structures like basement membrane is markedly disturbed. So because you should keep in your mind, this is very important point for you, that the neoplastic cells, okay, it's not like you are normal. Why? Because when you are sitting now, mostly you are sitting beside your friends, that's right? But there is no junction between you and your friends. But you are sitting between, and you are sitting on the same basement, let's call it basement membranes, right? So, very nice. But, what's going to happen to the neoplastic cells? First, they are going to lose their junctions with their neighbor cells, left and right. This is one. Okay, don't do it, because your behavior will be not good. Okay, then what else? What they are going to do? They are going to invade the basement membrane, and this is not also a good behavior. So, okay, you like Mercedes?
Yeah.
But in this case, we don't like it.
Okay.
Because this is abnormal mitosis.
Okay, I don't
Abnormal
like
mitosis. And this is how it looks like. This is how it looks like. When you see such things, it means the cell is really bizarre shape. It's really atypical mitosis, and it's going for a mad replication, like this. Then, you studied metaplasia, that's right?
Yes.
Then, what do you know about dysplasia and carcinoma in situ or in situ? These terms describe morphologically recognizable changes in differentiation that variously represent an adaptation to chronic injury in metaplasia. And what else? Pre-malignant changes in dysplasia, a cancer that has yet to invade basement membrane in carcinoma situ. Means localized cancer. Localized cancer. Not invading yet the basement membrane, localized. Then, what is dysplasia? What is metaplasia? And what is carcinoma in situ? Dysplasia, in terms that literally means disordered growth. Disorder in the growth. So it is encountered principally in epithelial cells. Mostly these plastic changes will occur in epithelial cells, not in mesenchymal cells. So, it is recognized based on several morphological changes, and whenever there is dysplasia, what you are going to observe, disorder in the growth, it looks more towards anaplasia and neoplasia. But it's still not invading. Not invading, and there is a loss of maturity, going back to the primitive. So you will see hyperchromasia, you'll see pleomorphism, you will see mitosis, you will see increased nuclear cytoplasmic ratio, but there is no invasion yet. And the degree of dysplasia, we have a low grade and high grade of dysplasia. It depends on the degree of maturation. So, let me show you here. The dysplasia usually will develop, okay, into malignancy, may develop, and the may is big in red color, not always. Dysplasia will go for malignancy, may. Uterine cervix and colonic polyp, because those who are sexually active, females, after maybe in their 30s or 40s, they are advised to go for something called pap smear. Maybe you heard about this, okay? Cytology, pap smear. Just to check the cytology of the cervix, whether there is any dysplastic changes, whether there is any dysplasia. So the cytopathologist will know. Then for the colonic cancer also, polyp, and it will be graded to low grade, high grade. Then dysplasia may not develop into malignancy. But high-grade dysplasia sometimes can be classified as carcinoma in situ. So this is how dysplasia will look like. Still, the basement membrane is not invaded, but it's going up with immaturity. Usually in normal tissue, this is the normal. You can't see such things. But here, can you see? Hyperchromasia, increased nuclear cytoplasmic ratio, pleomorphism, but going to the surface. This is a dysplastic changes. This is dysplastic changes. While carcinoma in situ is a lesion that's still not penetrating the basement membrane. And carcinoma in situ is often seen in skin, breast, bladder, and uterine cervix. So this is a carcinoma in situ, not invading the basement membrane. Once it will start invading the basement membrane, we call it invasive carcinoma, invasive cancer. So, cell with mutation, with transformation, hyperplastic, dysplastic, disorder in the growth, then carcinoma in situ not invading yet the basement membrane, then it becomes invasive carcinoma. This is how the story will start and how it's going to end. So, features of malignant tumor, cellular features are local invasion. This is cellular features. Local invasion to what? To the capsule and basement membrane. Metastasis. Metastasis usually a sign of malignancy. Seeding of body cavity, we call it transcolimic. Lymphatic spread to the lymph vessels and the lymphatic nodes, lymph nodes, and hematogenic spread. So metastasis, by definition, the spread of tumor to sites that are physically discontinuous with the primary tumor that marks a tumor as malignant. So metastasis, very important for metastasis. The invasiveness of cancer will permit them to penetrate blood vessels, we call it hematogenic spread, lymphatic spread, a body cavity transcolimic spread, as an example, peritoneal and pleural, providing the opportunity for spread. And this is the pathway of spreading. Either the cancer will directly seeding of body cavity, lymphatic spread, hematogenic spread. Then you can see. This is a primary cancer of what? Spreading to the lung. Spreading to the? Okay. Either through hematogenic or through lymphatic. Okay. Or sometimes tumor in the colon spreading transcolimic. Transcolimic means through body cavity to both ovaries in female. Okay? Lymph node metastasis, very important. Lymph node metastasis is extremely important because for breast cancer we need to check the axillary lymph nodes to see whether there is any lymph node metastasis. This is by clinical, and of course we'll go for radiology. Then we will go sometimes if the patient is going for mastectomy, radical mastectomy, they will remove also the lymph nodes. They will send to histopath to check with there is lymph node metastasis or there is no lymph node metastasis. So the significance of the nodal metastasis is very important for the prognosis and for the therapy. Because if there is a lymph node metastasis, sometimes they will give what we call it adjuvant or neoadjuvant chemotherapy before they will start with surgery. If they notice by radiology that there is lymph node metastasis. Why? They call it downstaging from stage 3 to stage 2. Reaching toward the end. Spread of lung carcinoma as an example. This is a lung carcinoma. Either spreading as a transcolimic to the pleural or by lymphatic to the lymphatic to the lymph nodes, or by hematogenic to the blood. Okay, this is for your information. So very important. Hematogenic spread is typical of sarcoma, but is also seen with carcinoma. As an example, osteosarcoma in the knee joint or in the lower extremity. Osteosarcoma is a benign or malignant? Malignant what? Mesenchymal or mesenchymal? What origin? Osteo. Bones, that's right. So osteosarcoma, sometimes the patient will present it to you coughing. Definitely you're not you. Yeah, but coughing. So presented with coughing. Coughing, why? Because there is a hematogenic spread. Directly from the bone to the lung. Lymphatic spread, transport through the lymphatic vessels, is the most common pathway for initial dissemination of carcinoma. Then, the pattern of spread follows the natural routes of lymphatic drainage. Very important you follow the anatomy, because that you studied anatomy. So for example, because carcinoma of the breast usually arise in the upper quadrant, outer quadrant, so they generally disseminate first to the axillary lymph nodes and then to the infraclavicular and the supraclavicular lymph nodes. Follow the drainage anatomy. Then the last. This is the major staging system currently in use in the American Joint Committee on Cancer Staging, and this system uses a classification called the TNM system. I'm not sure whether you heard about this before, no? TNM, you heard about TNM? Yes, very good, only one. Anyone else? Only one?
Yes.
You heard? Okay, only one? Anyone heard about it? No. TNM is very important. Now you're going to hear about TNM a lot, especially in systemic pathology, when we are going to teach you tumors. TNM is tumor growth. T refers to tumor growth. N refers to nodes, lymph node metastasis, and M refers to distant metastasis. So, as you can see here, there is no tumor growth, T0, then there is no lymph node metastasis, either distant or local, then there is no distant metastasis. So this is all stage 0, that's right? So we are all in this stage, because we don't have. For those who will have a tumor growth less than 3 cm, then only one lymph node metastasis to the local, then only one organ metastasis. So they are in T1, but N1, M, then more than 3 cm, T2, 2 lymph nodes, distant and local, N2, and if it's MX means more than one organ metastasis. Then this will be the worst and this will be the best. Okay? This is the worst, means advanced stage. Okay? So T for primary tumor, and N for regional lymph nodes, M for metastasis. Those are the key concepts for you, and thank you very much. Well, by this, we already covered your learning outcomes. The rest, because I used to teach, in many medical schools, so the rest is not included in your learning outcomes. Tumor, carcinogenesis, the promoters, initiators, the tumor immunology, tumor behaviors, all these not included in your, and we are following your CLOs, that's right. So I cannot go beyond, but it's in your slides, okay? Just a very rapid revision, okay, about what I already mentioned here. You know, this is a benign tumor, as you can see, rounded, no invasion, and this is just a repetition for the cancer, which it shows invasion. Here, as you can see, local invasion. This is how the metastasis will look like. It's liver metastasis. Liver metastasis, okay? And the epidemiology for the, it's not in your learning outcomes, but just for your information. For females, what do you think the most important breast? High morbidity, but not high mortality, because you know there is advancement in the early detection. For the male prostate, morbidity, also more than mortality, advanced in the early detection. But for both, mortality will be lung cancer. Lung cancer, okay? So the mortality is very high. Then, of course, there is a geographical variations also, it depends. And there is an age predisposing factors, genetics, and there is other predisposing factors. Okay, they say whenever you're getting older, there will be more chance to develop what? Cancer. Is this right or wrong? Yes, but sometimes it's wrong because there is a pediatric cancers. Yes, as leukemias in children, medulloblastoma in the children also, and there's other tumors, but it is retinoblastoma as an example in children. So, genetic predisposing factors, yes, the genetics play really a major role. Non-hereditary predisposing factors, as an example, chronic inflammation. Do you know why chronic inflammation? Do you know why? Chronic inflammation is a predisposing factor for cancer? You don't know. Because in chronic inflammation, there is a cycle of what? That's right, degeneration and regeneration. Degeneration, regeneration. So there will be sometimes with this degeneration, regeneration, genetic abnormality. And usually the cells that is going to transform, we call it non-lethal genetic abnormality. It means if the cell will die like necrosis, it will be better for us as a human being because the cell will die and we will get rid of it. But the problem that when the cell is not going to die, non-lethal genetic damage will occur. Then carcinoma will start. So from one single cell, you can see there is a tumor mass by growing. Then the transformation and the progression, okay, the cell cycle and how it's going to be affected and the process of transformation. All this is not in your learning outcome, so I cannot really touch it. I'm just giving you an overview. What is oncogenes, what is proto-oncogenes, and what is the, what we call, the genetic suppressor, okay? The tumor suppressor, and the DNA repair genetic defects, plus the tumor angiogenesis, how the tumor angiogenesis will occur. Then the invasion factors. What are the factors that lead to invasions? Detachment, attachment, degradation, and migration. And the metastatic genes, the chromosome abnormality, and how the carcinogenes is going to lead to genetic abnormality. We have the initiators and promoters. The initiators that initiate the carcinogenesis by mutation, others, and the promoters will enhance proliferation of initiated cells. Those are the usual suspects for cancers. Inflammation, chronic, teratogenes, immunosuppression, neoplasia and mutations. Chemical, radiation, infectious pathogens. Always incriminated. So the chemical carcinogens, those are the chemicals, hormones, radiations, viral carcinogens. What we call viral carcinogens? We call it oncogenic viruses. Oncogenic viruses. Then H. pylori also considered as a biological carcinogen. And how the cancer will evade the host defense. How? Okay? So you have everything here, but I'm not allowed to teach you all these because it's not in your... But I used to teach this, of course, for 20 years for the medical students. It's not included in your TROs. So the effects of tumors on the host, either location, anatomic, or either local or systemic, like hormonal production, bleeding, infection, acute symptoms, rupture and infarction, and metastasis. So this is what's been known as cachexia, reduced diet, fat loss, muscle loss, and this is due to the TNF and interleukin-6 and the proteolysis inducing factor. This is how the patient will look like. Cachexia. There is a paraneoplastic syndromes also. Paraneoplastic syndromes, Cushing's and others will occur due to... You remember when I said the cells looking bad, behaving? This is how they behave bad. Yes. Endocrine, a lot of endocrine. Then there is something called the grading. It is according to the differentiation. Well differentiated, poorly differentiated, and undifferentiated. So, where is the well differentiated? Where is the poorly differentiated? Where is the moderately differentiated? You should know from this grading of squamous cell carcinoma. Grading will be done by histopathologists. Okay? Adenocarcinoma grading also. So you should know which one is well, which one is poorly, which one is moderately. TNM already discussed. The lab diagnosis, biopsy cytology. And we have immunohistochemistry also, microarray. And the tumor markers is going to be discussed with cases. But the tumor markers, for your information, dear students, is any material, enzymes, proteins, whatever is going to be produced by tumor cells. Then we can measure and we can know that, yes, this type of tumor is
Dangerous.
present. That's right. But of course, we don't use it as a diagnostic tool, but to aid either in the diagnosis or to monitor the recurrence of the tumor. Very important. Tumor markers. We are going to discuss it in case studies. So those are all tumor markers that you have. And the last will be early detection of cancer by screening. It will lead to early diagnosis better. With that, thank you very much. So dear students, you should love pathology, so pathology will love you. Okay? If you have any question. Any question? Dear students?
No.
Anyone would like to ask any question? I'm ready. Ask. No question? Sure? All of you? This is extremely important lecture.